what's at risk if we can't continue to fund these studies, or that momentum is somehow stunted by, uncertainty and discourse?
I'm very sad to see what's happening over these last few months with many health-related institutions in our government, and particularly with National Institutes of Health, which is a national treasure of biomedical funding, produces several dollars worth of value for our economy for each dollar we spend. NIH has disproportionately funded some of the most exciting discoveries in the world, and certainly supported the work I've done with a project called BabySeq over 10 years ago, and then shortly after that, the project BabySeq. That is disrupting that health funding system is a great risk to progress and to the next generation of science. I think we're all very concerned about that.
This is Genetics for Healthcare, a podcast for patients.
Thank you for joining us for Genetics for Healthcare. This podcast is dedicated to helping patients and their caregivers advocate for a precision medicine approach to treatment, disease screening, and prevention. You can find us on Spotify, Apple Podcasts, YouTube, LinkedIn, Facebook, Instagram, and TikTok. Hit that subscribe button while you're there, especially on YouTube, so you can get alerts and updates on great informative episodes like this one. Today, I am honored to have Dr. Robert C. Green, medical geneticist at Harvard Medical School and the director of the Genome's Two People Research Program at Brigham and Women's Hospital in Boston. Dr. Green, thank you for being a guest on the podcast.
Great to be here, Rome.
So we love to hear the background of how you got to where you were. So can you share with us what attracted you to a career in medicine, and why specifically clinical genetics?
Well, my father was a small town doctor, so there was never any question that I was going to be a doctor, but the type of doctor changed quite a bit over the years. I initially trained in neurology because I was interested in the brain and consciousness and the nervous system, but I started to specialize in conditions that had genetic predispositions, and particularly Alzheimer's disease. And I got fascinated by the ApoE genetic risk factor that is a gene for risk of Alzheimer's disease when it was just coming out. And I designed one of the earliest research studies that was funded by NIH to explore whether people wanted this information and how it impacted them. What was the medical, the behavioral, psychological, and economic outcomes of learning genetic information about yourself? And this was back in the 1990s when almost nobody was doing this, and it was very, very controversial, before DTC, before anything. And then direct-to-consumer genetic testing came out. I think the earliest companies launched in about 2007. And all of a sudden, the work that I'd published on ApoE was highly relevant to what was emerging in the world of genetic disclosure, both in the direct-to-consumer world and in the medical world. And at that point, I thought, wow, this is the most exciting stuff I've ever experienced. So I did something a little crazy. As a full professor of neurology, I went back and did a second residency 25 years after I'd done my first one. And that second residency was in medical genetics. I got incredible training from the group at Boston Harvard's Longwood Genetics Program, and got board certified in medical genetics in 2011. So I'm an experienced physician scientist, but was rather new to genetics. And then, being rather new, I was able to bring some new thinking, different kind of thinking to some of the questions. And as we'll talk about, that's helped me out quite a lot.
You mentioned the early studies. What was kind of the reticence or the hesitation at the time? Was there a prevailing belief that people didn't want this information? There would be some kind of angst of knowing it?
There was, and there still is. The issues around disclosing genetic information have not actually changed since the 1990s. They have shifted. So I remember before I trained in genetics, I remember approaching a geneticist and asking, hey, why don't we give ApoE back to people who asked for it? And he said, absolutely not,
Really?
completely
Wow.
unethical. You should never do that. And I think the concern was that there was a basic public misunderstanding of genetics and that it was highly deterministic in all situations, which of course it is not. That people would hear a risk factor like an ApoE4 variant, and they would assume that they were going to definitely get Alzheimer's disease. They would have catastrophic distress, suicidal ideology. So there was that whole idea. There was a sense that if there wasn't a absolutely direct treatment available, that we in the medical profession should not be talking about these risk factors. That's changed a lot, both because we have more respect for patients who desire information now, and because there are more treatments available now. Um, and then there was a sense that's still true today that there weren't enough geneticists, there's not enough genetic counselors, and primary care docs and others wouldn't know what to do with this information. That's still kind of true today. So it's quite interesting, Rome, because the reasons haven't changed, but they softened considerably over the years. And there's been a set of pressures, both academically from within that I've helped, been one of the people who've helped drive, and also commercially from without, which has been knocking on the door, uncovering markets of people who actually do want genetic information.
I'm going to circle back on that point in just a second, but genomes to people, I've read that the mission is to translate genomics into health, right? And I've read that you stated that you have a vision to bring whole genome sequencing that could incorporate into preventative genetics and genomics into the healthcare system and eventually mainstream medicine to avoid devastating medical conditions. And we were talking before we went live. My background has been oncology, but the implications of our genes are wide ranging, not just, cancer care, but wide ranging. Can you explain? I mean, this may sound like a fundamental question, but explain to us what is whole genome sequencing and how is it being used today?
Sure. So, as many of your listeners may realize, the DNA is a large molecule that is made up of chemical letters. There's 3 billion of those letters. About 2% of that genome, that DNA molecule, uh, is are the protein coding genes. And there is sometimes the body changes one of those letters, what we used to call a mutation, we now call a variant. And if the body changes the wrong letter, or drops it, or deletes it, or duplicates it, you get a variant that might be harmless or it might be devastating. And so, what we're looking at in when we say whole genome, we're talking about a technology that actually decodes all those letters. But then, whenever you hear that term, you often have to think, okay, what are we then zeroing in on and interpreting? And so, whole genome sequencing, you then have a choice. Do I look at one gene? Do I look at 100 genes? Do I look at 5,000 or 6,000 genes? So when I say whole genome sequencing, I'm using it as shorthand for sequencing all those letters and taking a broad look at interpreting 5 or 6,000 genes. And when you do that, it's surprising how much you find.
I've heard you speak, I think most recently, a couple of years ago at the Precision Medicine World Conference, and you said that our current healthcare system is effective once a person is sick with cancer, heart disease, other diseases. But you were talking about the potential of genetics and genomics to bring about true healthcare, which is to prevent disease or keep patients out of the hospital. So if there's a healthy person watching this and they were to consider whole genome sequencing, how could they use that information to manage or prevent disease risk?
Well, I think that genomics the study of multiple genes and many different variations that you could be carrying is one of the most powerful ways to keep yourself healthy and to live a long life. There's so much buzz about longevity right now. Well, one of the best ways to live a long time is not to die early. And so if you can anticipate some of the medical illnesses that you might be vulnerable to, and you can take steps to look for them early or treat them early if you find them, it can truly help you live a longer, healthier life. Now, genomics is one element of this. There's science happening at so many different levels of evidence. So, genomics, which is the study of these variants in your genome, can uncover about 15% of individuals who are carrying a single gene mutation that puts you at risk for a significant medical problem. But that's not all. Your genome can also be used to look for the recessive carrier traits that you're carrying when you get ready to have children. And so you and your partner can know if you happen to be carrying mutations in the same gene, let's say cystic fibrosis or Tay-Sachs or any of hundreds of different recessive conditions that could result in a devastated child. That's still not all. You can look at 27 or so genes that specifically manage the metabolism of certain families of medications. And that's the whole arena of pharmacogenomics. And about 80% of people have an atypical response to at least one family of drugs that you might see through the years in your life. And that's still not all. There's something called polygenic risk scores, which is relatively new, in which you add up thousands of small effect size DNA changes and you build a bell curve and you place each human being somewhere on that bell curve. And each of us may be at risk, we may be on the tail end of risk for a common condition like heart disease, type 2 diabetes, prostate cancer, breast cancer, and several other conditions. And again, it's not a crystal ball, but if you know that you're at increased risk, you can take additional steps to monitor and catch things early. So these, just in the genome alone, these are 4 different ways you can look for and anticipate medical problems. And honestly, we're way past the time when we should be using this in day-to-day medicine. The value is unequivocal. It's potentially life-saving. We can debate about how many, if we were going to do 1 million people, we can debate about whether we should look at 3 genes or 20 genes or 81 genes or 5,000 genes. We can have a debate about that. But the fact that we're not using this routinely to anticipate, predict, and prevent illness, it's unfortunate today.
Yeah. I've been a part of product teams with the goal of developing polygenic risk scores as a product for cancer patients but there's challenges that continually come up that we had to overcome, and we didn't necessarily have the technology at the time to overcome those challenges. We needed more data, and that can be a very long tail. But when you talk about polygenic risk scores for, as you mentioned, Alzheimer's disease or diabetes, coronary artery disease, what are the challenges? How far are we away from having those types of products that people can access?
Yeah. The biggest challenge is that in the minds of the general public, genetics is still highly deterministic, meaning a large part of the public thinks that if you have a mutation, you're going to get the disease. They haven't quite switched to understanding that it is a probabilistic marker. And this is probably because of the earliest genetic test that was available and that captured the imagination of the public was Huntington disease. Huntington disease is 100% penetrant, meaning if you have the mutation of a certain size, you're definitely going to get the disease. So that captured our imaginations and gave this frightening determinism to all of genetics. Most of genetics is not like that. Most of genetics is if you have a certain DNA change or a certain polygenic risk score at the tail end of the risk, you are at increased risk. You're not definitely going to get it. That's good news and bad news. It's bad news because it's it's probabilistic. It doesn't tell you with assurance. But it's good news because you don't have to be as frightened about it. It's like a risk factor that we look for in all the rest of medicine. We look for high blood pressure. We look for elevated cholesterol. We think about family history and take that into account. So these are all ways that we try to risk stratify human beings in the practice of medicine and then give them the attention that they need. So if we can normalize that for genetics, if we can de-exceptionalize genetics, that would be a good thing. As you know, there's been this term about genetic exceptionalism, which means why are we treating this so very differently than other types of medical information? I'll also add that uh, procedural crime shows haven't helped because on
Right.
television, since DNA is a biometric, like a fingerprint, you get over and over and over again this notion that the DNA is precise and the DNA tells you the answer. So when people have gotten that kind of messaging, it's often confusing because DNA in healthcare doesn't work quite the same way.
Yeah. You mentioned rare disease, and just a statistic from the National Economic Burden of Rare Disease Study. It reports that more than 10,000 rare diseases affect 30 million Americans, 350 million worldwide. Half of those people are children, with a total economic burden of nearly $1 trillion. Rare diseases presents a massive opportunity for innovation and diagnostic efficiency, I guess, if you will, for treatment and development. And it's estimated that half of all of those individuals with a rare disease remain undiagnosed or misdiagnosed. And that leads to inappropriate care, um, a mountain of ineffective medical cost. But in 2013, your team launched BabySeq Project, which is the first of its kind randomized clinical trial where researchers are performing comprehensive sequencing of newborns. What's the potential of whole genome sequencing at birth?
Well, once again, when we launched this, when we started writing that grant in 2011, 2012, and we launched it in 2013, the prevailing notion was way too early for this, and that we were putting people at risk. We had colleagues who were aghast. They thought we
Mhm.
were, again, we thought we were going to possibly do medical harm. We were going to create catastrophic distress and waste a tremendous amount of medical resources. And I wouldn't say we've gathered evidence to completely reassure everybody, but we've been studying this now in a randomized clinical trial format, as you said, for 10 years. And the results are really very reassuring. We have found mutations that are medically actionable. We have found children who carried these mutations that actually already had the clinical features of the condition, but nobody had detected it yet. They didn't know to look
Yeah.
until you found the mutation and looked harder. We found mutations that mean a child should get a simple supplement, vitamin supplement, to prevent ongoing brain damage. We found mutations in babies where an adult cancer syndrome was in the family, and nobody in the family knew about it until we found it in the child. So the medical benefits have been startling. And we have demonstrated very clearly that the families so far who've enrolled with us were not extremely distressed. Even when they found out something, they were grateful for the information. Now, this is sort of because people self-select. In other words, if you don't want to know this information, if you know yourself well enough to know that it's going to be very, very upsetting, you probably won't volunteer for a study or a product when these become available. But among people who do volunteer and ask for this information and want it, there's very good accommodation, psychological accommodation to it. And then we've been tracking the spending downstream, and there is increased spending. You'd have to understand that if you find something, you're going to follow it up with echocardiograms or regular um, regular consultations with a specialist. But the costs have not been exorbitant given all the economic noise that follows a child's first couple of years of life.
When we look at our genes, that's certainly one aspect that we haven't considered in our medical chart or our health journey for prevention or risk, if you will. It's a more of a recent concept. But what other data points have you found, or omics, if you will, to be considered alongside of whole genome sequencing data to develop a more complete understanding of how our genetic expression can impact our lives?
Yeah, well, one way to answer that is to think about genetics as the tip of the spear for a whole revolution in proactive care. And if you think about genomics, there is a layer on top of that of epigenetics, what's controlling the genes to sort of turn on more intensively or less intensively. There's proteomics, in which you are modifying the proteins. There's the microbiome, and babies certainly have a lot of poop if you want to study that. Um, and then there's the whole arena of wearables, all sorts of ways to monitor your health. And there's various levels of evidence for both efficacy and cost effectiveness for all these different things, which are kind of, I think of them like waves of innovation that are moving us in the direction of preventive care and health maintenance rather than sick care. Genomics is probably the tip of the spear because there's the most evidence right now, today, that this can help you. But it's also colliding with the reimbursement system that we have today in our healthcare. And in that sense, it's breaking new ground. We have never been able to get third-party payers to even contemplate paying for preventive genomics, paying for a population testing. Now, it's just starting to crack in a few places. And one of those places, for example, in the UK right now, there is an initiative where Jewish families can get testing under the National Health Service for BRCA1 and BRCA2 sequencing. It's very limited, 2 genes, but it will be paid for. In certain countries around the world, in part as an outgrowth of our work in BabySeq, which has gone on for 10 years, there are now 27 different research studies or initiatives to sequence children or newborns. And some of these are in countries with single payer systems. And in some of them, they are actively talking about paying for this from day one because they recognize that if done correctly, it can actually amortize funding that you would later spend on sick children because you've been able to prevent something. There are a lot of unanswered questions about cost effectiveness, in part because we've never really done this on large populations. We don't exactly know what percentage of children who carry these mutations literally go on to develop the condition and what percentage don't. So it's hard to work backward and figure out how much cost you could save. But the bottom line is that the resistance is still there. Our whole American healthcare system is built around sick care, but genomics is banging at the gate.
Absolutely. Of course, I feel this way, right? We're reaching a tipping point for as long as you have changed hearts and minds, not only of consumers, but your colleagues, of the value of genomic information and incorporating that into the healthcare ecosystem. I just feel that there is a lot of momentum. Certainly in oncology, with the medical societies endorsing and placing these in our guidelines, the demand for genetic counseling. There's just, as you mentioned earlier, there's not enough genetic counselors, there's not enough talent. And with BabySeq going on for 10 plus years and the discoveries that you mentioned, it's a federally funded program of the National Institute of Health. And today, as we talk, there's a lot of uncertainty around what's going to happen with that funding. What's at risk if we can't continue to fund these studies, or that momentum is somehow stunted by, uncertainty and discourse?
Yeah. I'm very sad to see what's happening over these last few months with many health-related institutions in our government, and particularly the National Institutes of Health, which is a national treasure of biomedical funding, produces several dollars worth of value for our economy for each dollar we spend. NIH has disproportionately funded some of the most exciting discoveries in the world, and certainly supported the work I've done with a project called MedSeq over 10 years ago, and then shortly after that, the project BabySeq. So that is disrupting that health funding system is a great risk to progress and to the next generation of science. I think we're all very concerned about that. Some of this can be picked up by other countries. Other countries with a single payer system will be looking at what it means to do population screening. Some of this can be picked up by commercial laboratories and pharma companies, but I don't think there's any substitute for the kind of fundamental research that NIH has provided.
Yeah. One of the positive things that came out of, I guess, this is a group of you and your colleagues convened and formed Rapid. I don't know if it was an entity before, but Rapid is the first opportunity of its kind funded in the US to reduce the diagnostic odyssey for rare disease patients. And it's self organized amongst your peers. And you guys produced a white paper that synthesized the perspective from healthcare providers, academic researchers, lots of folks, to identify the critical bottlenecks that has to be addressed with accelerating the progress of access to whole genome sequencing, continuation of the science for the benefit of rare disease. You will post that link on the episode page because the white paper is public. But the first bottleneck, the first objective priority is integrating the data into the healthcare system, which, I mean, it's easier for someone else to get access to my bank account than it is for me to get access sometimes to my own, healthcare records, because of the fragmentation of where it's at. But this is a massive effort. What type of digital tools, or even do you see AI playing a role in addressing this number one problem of integrating this omics into our healthcare system?
Yeah. To recap, you're exactly right. There was an initiative called Rapid that was put out by ARPA-H, a funding body within the federal government. They convened an in-person meeting in San Francisco, and while most of us were flying out to San Francisco, was when the first freezes came through from the new administration, and that meeting was canceled. So the people who were flying out to San Francisco decided to get together on their own and self-organized, and we got together in on our own and talked about these topics. and then with leadership from Melissa Handel and others, pushed that white paper out. And it was a great moment because we were sad that the federal government people couldn't attend. The whole purpose was for them to attend and talk about this funding opportunity. But it was a great moment of flexibility where investigators talked to each other. So that was an interesting day. The white paper then came out, talks a lot about the themes you mentioned. We have almost a medical sociology problem that we've alluded to, where we don't think, where doctors themselves don't think that we should be bringing this information into medical system yet. They don't think we're ready. But even among doctors who do, as you mentioned, there is a question about how do you do it. It's particularly for the rare disease arena. It's these are somewhat esoteric conditions. There's a lot of them. There are a few rare disease experts around the world. The knowledge can be siloed. All of this points to an opportunity for big data solutions, and specifically, more recently, as we've uncovered the power of AI solutions. And there are people way more brilliant than me that are working on this at multiple institutions. But the overview goes like this: can you use AI to more rapidly interpret genomes so that that doesn't bottleneck the situation? Can you use AI to keep the knowledge base of variants up to date faster? Can you use AI to even chat with people about pre-test, what we now would consider pre-test counseling or post-test reassurance? Can you use AI to update the rare disease knowledge resource that we need when you find a child that is at risk? And then what a lot of my colleagues that day in San Francisco were talking about is, how do you bring this information into the existing electronic medical records so that it's accessible? I mean, you realize, Rome, that quite a few labs and are still faxing reports to doctors' offices or to hospital systems, where they can sometimes get scanned and uploaded into the EHR. So linking all this together in a rational way with a fragmented EHR system and a fragmented healthcare system remains a tremendous challenge.
And this is why I'm passionate about patient advocacy and self-advocacy, because patients are learning more about their healthcare and their genome from their smartphone. Dr. Google, even. There are patient advocacy groups on Facebook or TikTok or other social media platforms that are moving this movement forward: self-empowerment, and self-advocacy. But at the same time, it opens the door to misinformation, which becomes a problem because many clinicians are not as proficient in the clinical genetics, and every healthcare system doesn't have a Dr. Robert Greene or a genetic counselor. And from conversations that I've had with patients, physicians, a lot of them are discouraged or dismissed or are dismissing certain tests because of the information, or they're just not clear. Even the time factor associated when a doctor is face to face with a patient, having to deal with their healthcare, there's just not a lot of time to answer the questions pertaining to the visit and genetics or genomics, or to help that patient sort through a stack of information that they found. Do you see a need in the market for a human, someone that can provide navigation services, not only for genomics once a person, let's say a lung cancer person is diagnosed with cancer, but for um, a family that has a sick child or someone that has a rare disease? Do you see a need for those types of organizations or companies to provide that service? And what would that qualification have to be to bridge the
Yeah.
gap in the lack of experts?
Well, you've expressed it beautifully. I think that first of all, there is an entire ecosystem around the rare disease of childhood where affected children, children who know that whose parents know they have something wrong, are building advocacy groups, and then there's umbrella groups like Global Genes or RareX that uh, sort of organize the advocacy groups. There's the Rares One program that Chan Zuckerberg has supported. So there's a tremendous ecosystem of self-efficacy, self-empowerment that families who have children affected are building and have built because of the limitations you've just described, because their pediatricians aren't experts, because they felt that they wasted years chasing a diagnosis that nobody could figure out. Sometimes these are solved by genetics, sometimes they aren't. Sometimes they're treatable, sometimes there aren't. Sometimes there's clinical trials that once you learn that a child has a particular syndrome, they can be enrolled in. But look, things are changing fast. Some of these genetic conditions are being treatable with new cell and gene therapies, gene editing techniques. There's been some predictions, maybe they're overblown, but there's been predictions that 80-90% of genetic conditions could be treatable with gene editing techniques within the next 10 years. So this shifts the focus not only on the incredibly valuable work that these advocacy groups are doing for affected children, but shifts the focus to finding them earlier and earlier so that when you treat them, you can treat them before the irreparable damage is done. Um, so I do think that we're in an era and an age where families have to be self-empowered, both for proactive care and for care of rare diseases, because no healthcare system is fully up to snuff in meeting those demands for everyone. Um, I do think that there is uh, there is a question of misinformation, but by and large, when people are motivated, especially with their own child's illness, they are genuinely seeking serious scientific support and medical support, and they are finding the proper experts to advise them. So, I'm very worried about misinformation in general. I'm very worried about misinformation in science coming from political agendas. Uh, in this particular area, there's misinformation that will make people fearful. They're super concerned about privacy, perhaps more than is necessary. There are unusual thoughts out there about if my genome gets analyzed, is somebody going to then come in and edit it? There's very fringe concerns that border on the conspiratorial. But look, we can't stop this progress. This is mainstream. There's going to be treatment and preventive measures for thousands of genetic conditions that, if applied properly, will save millions of children from horrible diseases. And this is going to be a very exciting development.
Absolutely. And I really appreciate you being generous with your time, Dr. Green, and coming on Genetics for Healthcare to talk to our audience. And we love to ask our guests for 3 practical tips for our listeners. And in this case, there may be someone out there that has had their genome sequenced and, maybe put the information, in a folder, or there are families who are considering that for a family member or a child or themselves. So, what are 3 practical tips that you can share with our listeners to help them apply this information to improve their health care? Maybe not immediately, but long term.
Sure. So, tip number one, if you have cancer yourself, or you have a child with a rare disease or a mysterious disease, in both of those cases, consider asking about genomics. Consider asking, if you have cancer, has my tumor been analyzed, the genome of my tumor been analyzed? If your child has a mysterious illness, consider asking your pediatrician, should we be getting genetic testing? All right, that's tip number one. Tip number two, if you're a healthy adult, consider talking to your doctor about some form of genetic screening. So that could be, doesn't have to be whole genome sequencing, which is still pretty expensive. It can be a couple $100. Typically won't be covered by insurance, but it can be a couple $100 for a gene panel that's 80 genes, 100 genes, 163 genes, whatever. There are companies who can order this, and ask your doctor if they would order it for you or would send you to somebody who could order it. There are also online medically rigorous services online. And then if you have a child of any age, enroll in free programs if they're available in your state for pilot programs for genome sequencing. There are more of these coming online in the years to come. Or you can look for commercial programs. In full transparency, I've co-founded a public benefit company called Nurture Genomics. And if we're still functioning at the time that you air this, go on to there and take a look at that offering. It's pay out of pocket at the moment, but we're going to be trying to integrate this into healthcare systems, integrate this into employer offerings, so that it's far more than a consumer-facing product. But people can sign up and have their own children sequenced. So those are three tips, I think, for people to consider as they want to dip their toe in the genomics revolution.
And we'll have the link to Nurture Genomics and some of the things that Dr. Green has shared with us as resources on the episode page on genomicsforhealthcare.com. Dr. Robert C. Green, medical geneticist at Harvard Medical School and director of the Genome's Two People Research Program. So I also understand you gave a recent TED Talk. Tell us about that.
Well, I fulfilled a lifelong ambition by being asked to give a main stage TED Talk, and I gave it on the phenomenon of newborn and childhood genomics screening. And it was a fascinating experience because you have to shape your message down to 12 precise minutes. But I was very pleased. It should be coming out in the next few months if it's not out already. And again, I'm just trying to get people to understand that while genomics is complex, you can use this as a way to stratify risk in children and move yourself forward in terms of screening those children to avoid treatable conditions. Did you know there's over 400 treatable conditions today, and many more are going to be coming online in the next few years?
Incredible. Dr. Green, thank you so much for being generous with your time and sharing as much as you did with our listeners. Thank you for being a guest on Genetics for Healthcare.
My pleasure, and thank you for having me.